Welcome to our learning corner where today we'll be discussing panic disorder. So we'll be speaking about the neurobiology of panic disorder. We'll also be touching on the clinical features according to the DSM-5, and we'll also be speaking on how it is that we can actually treat panic disorder. We'll be looking at some evidence-based care as it relates to this mental health issue. Before we get in, let's consider the case of a 28-year-old woman who is driving home from work when suddenly her heart begins to race. She feels short of breath, dizzy, and then becomes overwhelmed by an intense fear that she might faint or die. She pulls over convinced that she is having a panic attack and she calls 911. In the emergency department, no cardiac abnormalities are found. This episode actually represents what we call a classic panic attack. Now, let us look at the physiological processes that are involved in panic disorder. Now, as it relates to neurocircuitry, there is a loop that's involved between the amygdala, the hippocampus, and the medial prefrontal cortex. Dysregulation in this network drives threat detection that is off the walls, and top-down regulation of fear is also impaired. The insula contributes by amplifying interoceptive awareness, and when we say amplifying, we mean really amplifying interoceptive awareness, while the periaqueductal gray mediates defensive responses. The false suffocation alarm theory suggests that individuals with panic disorder have hypersensitive chemoreceptors in the brainstem, which eventually leads to an exaggerated panic response to CO2 fluctuations. The HPA axis is also implicated. Now, normally stress activates the CRH, the ACTH, and cortisol release. But in panic disorder, dysregulation may contribute to recurrent hyperarousal. Interoceptive conditioning as a result of this repeated hyperarousal further perpetuates the cycle. Small, benign, harmless bodily sensations can actually be misinterpreted as catastrophic, and this can trigger a panic. Talk about making a mountain out of a molehill. Now, the sympathetic and parasympathetic nervous system is also involved in panic disorder. Let us look at sympathetic and parasympathetic nervous system in terms of a vehicle. Now, the sympathetic nervous system, let's consider it as the gas. Now, where this is concerned, rapid mobilization occurs and the body is mobilized, the heart rate is increased, there's increased breathing, there is increased norepinephrine surges. Now, where the parasympathetic nervous system is concerned, consider it as being the brakes of the nervous system. Now, the PNS, the parasympathetic nervous system, usually restores calm, but where there is dysregulation, this can lead to delayed recovery. In some cases, the dorsal vagal system dominates, and this results in a shutdown or a freeze. Ultimately, panic disorder reflects a dysregulated balance between the sympathetic nervous system and the parasympathetic nervous system. Now, there are certain neurotransmitters and hormones that are involved in panic disorder. There is norepinephrine, serotonin, GABA, and in terms of hormonal responses, you have adrenaline and cortisol. Now let's zone in on the hormonal responses, adrenaline and cortisol. Now, we know of adrenaline's role in the fight or flight response, which we'll speak about a little bit later. Acute surges of adrenaline and cortisol supports the fight or flight response, and dysregulated patterns may contribute to chronic vulnerability. Speaking of the fight or flight response, where the fight response is concerned, the body actually prepares itself to fight a threat. And this usually happens when the body is hyper-aroused during an active panic attack. So as the body prepares to fight, increased blood flow is sent to the organs, sent to the muscles so that the body can actually survive a perceived threat. Where flight is concerned, the same thing happens where blood flow, oxygenated blood is pumped to the muscles. However, the body is actually preparing to run away or to evade the threat. Unfortunately, there is also the freeze response, where dorsal vagal dominance can cause numbing, dissociation, detachment, or complete shutdown. This can often be linked to trauma and bodily memory networks. The body keeps the score. The body remembers. What are some causes of panic disorder? Let's look at the origins. According to the biopsychosocial model, there can actually be genetic vulnerability, in other words, nature. Temperament can also contribute to a heightened propensity of having panic disorder, such as anxiety sensitivity. There can also be life stressors, which is where nurture comes into play, and the predisposed genetic factors can actually be catalyzed by life stressors. We can also consider, in terms of origin, learning mechanisms. There can be interoceptive and exteroceptive conditioning, which sustains avoidance and actually reinforces or maintains fear. Then there is trauma and adversity. We spoke about nature versus nurture before. Nurture comes into play where trauma and adversity is also concerned. When an individual encounters trauma and encounters extreme stress and adversity in life, this can actually sensitize the autonomic and interoceptive responses to be on alert for situations that can actually trigger a panic so as to avoid it. But this is actually dysregulation and not a true reflection of how the system should actually work. Then there can also be cultural or contextual factors. In some cultures, experiencing emotions is more felt in a somatic way than others, and this can heighten the propensity for having a panic disorder. There are common comorbidities that actually occur with panic disorder. Some other very common and very likely mental health issues or mental illnesses that can occur with panic disorder. Panic disorder often co-occurs with agoraphobia, major depressive disorder or other anxiety disorders. Substance use can also be an offshoot or a byproduct of panic disorder, as persons actually try to self-medicate to get rid of the symptoms of heightened hyperarousal. PTSD is also commonly co-occurring with panic disorder. Clinical management then may require sequencing, such as treating severe depression or substance misuse before initiating panic-focused therapy. Let us look at some evidence-based psychological treatments. CBT and panic control treatment are actually the gold standard intervention which combines psychoeducation, breathing retraining, interoceptive exposure, cognitive restructuring, and situational exposure. Speaking of exposure, exposure-based strategies can actually build inhibitory learning and challenge catastrophic beliefs, reduce avoidance, and this will help to deal with the onset of panic disorder. Interoceptive cues can also be induced via exercises such as spinning, stair running, or even drinking carbonated beverages. EMDR, which stands for eye movement desensitization and reprocessing, can be useful whenever it is that panic is linked to traumatic memories or phobic cues. Mindfulness and acceptance-based approaches can help patients to tolerate sensations without catastrophic appraisals. There can also be somatic and regulation focused adjuncts. Trauma sensitive yoga can be used to improve autonomic regulation as well as interoceptive awareness. Now, we cannot heal from trauma, which is usually occurring as a result of lack of choice, with more lack of choice. So, where trauma sensitive yoga is concerned, in a very safe environment where invitational language is used to build awareness of accessing choice, choosing to get into a particular shape or not, this can help to build awareness of bodily functions, build awareness of a feelable feeling, a feelable emotion, or even observing the observer. This actually builds the brain muscle as it relates to noticing triggers, noticing the environment, and noticing what's happening inside the body. Interoceptive awareness. As it relates to pharmacological treatments, you have first line, which are SSRIs and SNRIs, second line, which is TCAs, MAOIs, as well as benzodiazepines, which actually, a caveat, it provides rapid relief, but it can carry risk of dependence and relapse. This is then only recommended for short-term or adjunctive use. In terms of treatment typically continues for 6 to 12 months after remission with an emphasis on relapse prevention planning. Now let's look at some therapeutic techniques for panic disorder. There has to be psychoeducation about the panic cycle. Psychoeducation definitely helps with validation and being aware of what is happening while a panic attack occurs. Interoceptive exposure also helps with tracking and expecting and rating. Cognitive restructuring or cognitive reframing helps to deal with offsetting catastrophic thoughts. And instead of, as we mentioned before, thinking of a mountain when there is a molehill, reframing can take place. Breathing retraining can also be useful, but just a word of caution, there's some persons who actually have anxiety related issues that when they're being taught how to breathe properly, quote unquote, this can also trigger another panic where the person may be having thoughts of why am I not getting this right, which can actually induce a panic attack. So this must be used with caution, and this must also be used with care, and there has to be rapport, and the person has to really feel safe in your presence. Then there is grounding, such as grounding with the senses, 5, 4, 3, 2, 1. 5 things that you can see, 4 things that you can feel, 3 things that you can hear, 2 things that you can smell, 1 thing that you can taste. This helps to ground the body in the present moment and to take the mind off distracting thoughts that can lead to a panic. And then there's BLS, or what we call bilateral stimulation, which is usually involved in EMDR. So BLS can include eye movements, it can include auditory BLS, it can include butterfly hugs or tapping, which can help to keep the body, keep the mind in the present moment while a traumatic target is being processed. This desensitizes the individual to the intensity of the particular target or memory. Then there is yoga-based regulation, as we had mentioned before, trauma sensitive or trauma informed yoga. Now, while we speak about therapeutic techniques and therapeutic interventions and evidence-based care, we cannot leave out the community. No man is an island and no man stands alone. There has to be collaborative care that involves the community. Collaborative care models integrates primary care and mental health. Family involvement is also very key. And when we say family, we also mean the partner, so the spouse, caregivers, individuals that live in the household. This can help to reduce accommodation behaviors that accommodates the panic disorder. Then there is peer support and crisis planning, where peer support is concerned. Persons can learn from others how it is that they actually manage their panic attacks. You can be learning from somebody who is not just a professional, but somebody who feels, looks just like you. Crisis planning or safety planning can also put the power in the hands of the individuals to play the tape forward or to plan ahead, such as what tools am I going to use if I have a panic? Who can I call if I am having a panic attack? What can I do? Where can I go? Things like this can help to increase perceived self-efficacy when a panic attack is happening and decrease feelings of hopelessness. Then there are lifestyle interventions. Sleep is extremely important. So sleep hygiene can be looked on as it relates to panic disorder, as well as exercise, regulating the body's natural hormonal flows, decreasing caffeine use, decreasing nicotine use, and any other drugs or anything that alters how it is that the body functions. Then there are cultural adaptations that also has to be looked at. Attention has to be paid to stress signals or symbols of stress. What is stressful in this culture as opposed to another culture? Multicultural awareness or cultural humility has to be ensured when looking at panic disorder. Then there is health literacy and access barriers, or barriers to accessing healthcare, that also needs to be considered. In the final analysis, panic disorder is actually highly treated. It's highly impairing, but it is highly treatable. Optimal outcomes come from combining CBT with exposure-based strategies and first-line pharmacotherapy when needed. Trauma-informed and somatic approaches such as eye movement desensitization and reprocessing, or trauma-informed and trauma-sensitive approaches such as yoga, can address deeper underlying core beliefs that affects deeper dysregulation. Clinicians have to tailor care to cultural contexts and have to be aware of comorbidities such as substance misuse, substance abuse, anxiety, agoraphobia, that can also be happening with panic disorders. These cannot be ignored. The patient has to always be looked at in terms of a person-centered approach, and we always have to plan for relapse prevention and functional restoration. Thank you for coming to my learning corner.